CHÉOS exists to improve health outcomes for BC, Canada, and the world. Learn more at chaos.ubc.ca.
Welcome everyone to Work in Progress. It's a nice day in Vancouver. The sun is out. Looks like spring is in the air, or at least coming. I'd like to start by acknowledging that at CHÉOS we are based on the unceded territorial ancestral lands of the Squamish, the Musqueam, and the Tsleil-Waututh nations, and I'd like to acknowledge that it's incumbent upon us to make sure that we take our presence here and the stewardship of their ancestral land seriously. I'd like to also welcome our two new speakers today by saying a few words about our presenters. So Dr. Alana Flexman, I just, I met her recently and was very impressed with her. She's an anesthesiologist. She's the director of the anesthesia research in the Department of Anesthesiology at St. Paul's. She's also a clinical associate professor in the Department of Anesthesiology, Pharmacology, and Therapeutics. Her research is focused on neuroanesthesia, including perioperative stroke and brain health. She's one of those people who can, use these dangerous chemicals and drugs that are now causing so much devastation in our community safely. And so, welcome, Alana. And Jaycee, I haven't met you yet, but welcome as a co-presenter. Jaycee is a first-year graduate student at the University of British Columbia. She's pursuing a master's in pharmacology, anesthesia, and therapeutics, and has research experience in the area of clinical outcomes following geriatric inpatient admission, as well as incidences of burnout amongst healthcare professionals and trainees. Thank you very much for presenting, and I should say that Alana is a CHÉOS scientist, so we're very pleased to have her here present at Work in Progress rounds. And if you want to have a few minutes to reflect on things beyond your presentation, feel free to do so, Alana, and then it's over to you.
Great. Thank you so much for that kind introduction and for having us. It is very exciting to be joining CHÉOS. This is my first Work in Progress presentation. And Jaycee and I are very excited to share some of our research with you, to meet some of you, and hopefully make some connections with people within CHÉOS as well, which would be great. I'm just going to share my presentation. Just give me one sec. So Jaycee and I are going to take you through a bit of a journey today. So we're going to go through a bit of a background on perioperative stroke so that we're all on the same page, and give a bit of context to our study, including the study justification and what the questions that we're trying to address. Then Jaycee will give an overview of our study objectives, methods, and our preliminary analysis and results. And then I'll take you through some contextualization of those results and next steps, and hopefully engage in a bit of a discussion at the end with some of you. So first, we'd like to make some disclosures and acknowledgements. So I am supported by the Department of Anesthesiology here at St. Paul's Hospital, as well as the Michael Smith Research BC. I'm grateful for that support, as well as Providence Research. And I do receive financial compensation in the consultant fees from the Canadian Journal of Anesthesia and Up to Date, which I don't believe constitute a conflict here. We'd also like to acknowledge our study team. So clearly there was a lot of brainpower that went into this beyond Jaycee and I. So we'd like to acknowledge all the people listed on this slide from a variety of different institutions, including UBC, CHÉOS, and across the country, and from both neurology and anesthesiology and epidemiology, as well as biostatistics. So what we'll do is we'll go through an overview of perioperative stroke, and then the outcome after perioperative stroke based on our analysis, next steps, and then feedback and questions. So to start with a bit of background. So the first thing to understand is what the definition of a perioperative stroke is, which is distinct from a stroke that occurs outside of the surgical context. So most of the literature uses this definition as well as guidelines that it's considered a brain infarction of ischemic or hemorrhagic etiology that occurs during surgery or within 30 days of surgery. So this is the typical definition and time frame used in relation to surgery. When we think of the etiology of perioperative stroke, it is distinct and unique from strokes that occur in the community that are not related to surgery. And we also have stratified most of our discussion and our study analysis based on cardiac versus non-cardiac surgery, because these two groupings have quite distinct etiology for stroke and risk factor profiles. So when we look at non-cardiac surgery, you can see that there's embolic phenomenon for stroke is the most common. In this particular study, the unknown category happened to be quite large. And we often don't actually understand well why stroke happens in non-cardiac surgery. But thrombosis is another major risk factor, as is hypoperfusion, so low blood pressure, possibly during the surgery or anesthetic or even after the surgery. Hemorrhage constitutes a pretty low number of strokes in this population. And when you can see that with cardiac surgery, that changes somewhat. So the embolic phenomenon in cardiac surgery is by far the most common etiology for stroke. And typically these emboli come from the heart based on the surgery that's happening. So whether it's a clot or even air sometimes that goes to the brain. So that makes it quite distinct from non-cardiac surgery. With cardiac surgery, you can break it down even further, and you can look at what happens in the early period, so in the first 48 hours after surgery versus the late period. And what we know is that there's distinct risk profiles for those two periods. So in the early phase, it's more common to have a hypoperfusion stroke, so having low blood pressure, which is a common complication of cardiac surgery and bleeding. And also thromboembolism from, because they're instrumenting the aorta, intracardiac sources, and bypass. When you go into the late period, you're looking more at the typical stroke risk factors, atherosclerotic risk factors, and comorbidities that drive the risk of stroke. When we look at the incidence of perioperative stroke, again, you have to look at both these populations separately. So in non-cardiac surgery, if you took all surgical types, you would only see an incidence of about 0.1%, which is fairly low. But if you start to enrich your population with higher risks, for example, with cardiac risk factors, you see increases up to 0.7% in a large trial of higher risk cardiovascular patients. And if you have a history of ischemic stroke, it's one of the highest rates, which is almost 3%. Covert stroke is when you have a subclinical stroke that's not clinically recognized, but if you image the patient, you know they had one. We only recently recognized that this happens in 7% of patients who have a non-cardiac surgery and 40% who have a cardiac surgery. And cardiac surgery also varies quite a bit by the type of surgical procedure you're having, whether it's an isolated bypass procedure, which is relatively straightforward. It's only 0.5 to 1%. But if you undergo hypothermic arrest, then obviously those are the highest risk cases, and it's about 5% in the literature. I feel like this slide sums up a lot of the problem with perioperative stroke. So this is looking at different incidents over time of different perioperative complications. And what they've included here is death after surgery, myocardial infarction, and stroke is the top line. And what's concerning is that most of the other serious complications after surgery are declining over time, but perioperative stroke, for some reason, is going up over time. And we don't know the reasons exactly why this is happening, but there's likely, I would hypothesize, that it's an under-recognized complication that we haven't spent a lot of time trying to mitigate or understand, as well as these other complications. In contrast, stroke after cardiac surgery is a more recognized and emphasized complication. And you can see that there's been a decline over time in the incidence of perioperative stroke, which is reassuring and likely due to advances in surgical and anesthetic technique over the decade. So when we think about who's at risk for perioperative stroke amongst our surgical patients, this was an analysis of the NSQIP database, which we are analyzing as well. And we'll explain more about that database later. You can see that there's several identified risk factors. These are all pretty consistent in the literature. Age is a very consistent increased risk factor, but history of stroke is also consistently found, as well as the other ones you see listed there. Interestingly, higher BMI is actually protective in this analysis for having a stroke. And based on their analysis, they stratified people into different risk categories. And you can see that if you're low risk, the risk of stroke is very low. But if you get into the highest risk category, the risk goes up to 2%, which is as high as a myocardial infarction risk. It also varies by procedure, as you can see, and age quite clearly here. So we do have to consider that when we're looking at risk after stroke. And this is just another study that used a different set of data that added some additional risk factors, such as atrial fibrillation, valvular disease of the heart, and renal disease in specifically in non-cardiac surgery. And when we look at cardiac surgery, there's another whole host of risk factors that are quite unique to that specific surgery, including, for example, like the type of surgery they're doing, whether there was manipulation of the aorta, the number of grafts, whether the patient was transfused. So you can see that there's quite distinct risk profiles for non-cardiac and cardiac surgery and across the perioperative period. So you think, well, what can we do to stop this? Can we prevent perioperative strokes in high-risk patients? What does the evidence show us? And probably one of the most established ways to reduce risk is if someone's had a stroke, which we know is a high risk for having another stroke, is actually how long you wait to do surgery after that stroke. If you don't wait, if you do it within 3 months, the rate of stroke is very high for those patients of having another stroke. And this is a subset analysis of just having joint arthroplasty, and it's quite impressive that 20% of patients who have surgery within 3 months of their stroke will have another stroke, which is quite devastating. And it's only recently been recognized that this is a high risk for patients. In the same analysis, they found that risk stabilized around 6 to 9 months. So waiting about that long after a stroke is advised when the surgery is truly elective. Obviously, we can't wait for everything. So emergency cancer surgery, you can't wait that long. But if you can, that's ideal. A lot of other interventions have been looked at over the years. I've just really distilled this down to one slide, but you could spend a whole hour talking about this. So people have looked into bridging anticoagulation in patients with atrial fibrillation. So should we take them off their anticoagulation, put them on heparin, make sure they have a minimum period of being off their anticoagulation, but actually a big trial did not show that reduced stroke risk. Preoperative metoprolol was tried as a way to reduce cardiovascular complications, but actually found it increased stroke, probably because of hypotension, we wonder, because it increased in that population. The follow-up trial to that looked at aspirin. It didn't meaningfully modify stroke risk to add aspirin preoperatively, although people had thought that was a way to mitigate risk. And hypotension has kind of a variable relationship in non-cardiac surgery, whether it predicts a stroke, but it does have a stronger and more consistent relationship in cardiac surgery. So hypotension is probably somewhat important, and particularly in cardiac surgery, but we haven't really established that well. And then carotid artery stenosis is a known risk factor for having a stroke, but it's not clear that intervening on that is going to change that outcome. And specifically in cardiac surgery, it doesn't improve your outcome after cardiac surgery to have a concurrent carotid endarterectomy, for example. So we're actually left with relatively few ways to mitigate risk. We know that delaying surgery when we can is a good way to do it. But there's a lot of other things that we either don't know if it works, or they actually were shown to not be effective for stroke specifically. And this is an area in general for focus for our research program, to look at various parts of this whole pathway to see if there's other ways to establish ways to improve outcome after a stroke or to mitigate the risk. So the focus of our study is more around outcomes after perioperative stroke. So if you do have a stroke, then how can we have that patient have the best outcome possible? And this is probably the least studied part of perioperative stroke to date, especially in non-cardiac surgery. So based on the evidence that's published currently, we do know that there is patients who have a stroke after surgery clearly do worse than patients who don't have a stroke, and that makes sense. But what's actually quite impressive is that there's a very high rate of mortality. So we're looking at 20 to almost 50% mortality rates in the published literature, which is incredibly high for a perioperative complication. Length of stay, not surprisingly, is increased. And then long-term, there's some evidence that these patients are at risk for recurrent strokes and decreased or mortality long-term, as well as cognition issues. As part of our preparation for this study, we did a preliminary sort of pilot analysis of 1 year of the NISQIP data set, where we took, this was almost 900,000 patients. We looked at who had a stroke and who did not have a stroke in this cohort. We stratified them by cardiac or non-cardiac surgery because of those key differences that I outlined. And what we found is that if you have a stroke after surgery, we confirmed that basically your risk of having an in-hospital death and having an adverse discharge, which is not going back to home, basically, is very high for these patients. So we know that stroke confers a very negative outcome on our patients. And our question then was, how can we better understand who does well and who doesn't do well, possibly identify modifiable risk factors, and also better understand prognostication, which, as I'll explain later, is a key part of their management. So why is the outcome so poor in patients who have a stroke after surgery as compared to those who have a stroke on the street or in the community and come into the hospital? And likely it's a synergistic interaction between the state that surgery produces, which is a pro-inflammatory state. They have disruption of the blood-brain barrier potentially from the stroke, but then you superimpose other pro-inflammatory mediators that worsen that. And then you have a hypercoagulable state that's induced by surgery. So you've got all these different factors that compound the original stroke, and then that leads to a very high mortality and poor outcome, poor functional outcome, as compared to even stroke that happens outside of the surgery context. We also know that patients who have a stroke after surgery are typically not recognized, they're not imaged, and they're not intervened on nearly as much as patients who have a stroke in another setting. And it's likely because there's all these other factors going on. They're sedated, they have pain, there's a low awareness about the complication. And this small cohort just confirmed that few patients, or they had large delays in getting imaging that you wouldn't see if someone appeared in the emergency room, and they didn't receive much treatment, for example, thrombolysis or thrombectomy. As another factor, we've done 2 surveys on patients as well as anesthesiologists, and basically we found that there's significant knowledge gaps around perioperative stroke. Anesthesiologists don't routinely discuss it with high-risk patients, so the patients are also not aware of the complication. We confirmed that with their survey. And so people just don't know about it, and maybe the patient doesn't report it to the nurse if they have a sudden onset of symptoms and don't realize that they're high risk for the complication. So accurate prognostication, if you have a stroke, the reason that it's important to understand what your risk is and how we can risk stratify you is because there is a variety of different ways to intervene and treat an acute stroke. So most of these are ischemic strokes, so I am going to focus on that as a treatment. You can go anywhere from palliation, so the patient may not receive aggressive therapy. They may be eligible for systemic thrombolysis, like alteplase. And the most aggressive would be getting an endovascular thrombectomy, which is where they put catheters up into the brain vessels and are able to mechanically pull out the stroke, which has only in the last 5 years been recognized as being a highly effective way to treat selected acute ischemic strokes. So when these decisions need to be made quickly because of the timeframes are very tight for these interventions, and the patient's prognosis in general, life expectancy is actually quite an important factor in the decision-making here. And just to further outline that thrombolysis is an option for surgical patients, provided there's more than 2 weeks out from their surgery, which would still qualify as a perioperative stroke, but the timeline is tight. They have to be within 4.5 hours of their symptom onset. And thrombectomy is a more flexible option. It can go up to 24 hours. Surgery is not a contraindication, but they also have to be highly selected as well. So as I outlined before, the factors that lead decision-making for treatment, the one that we're focusing on here to try to fill in the gap here is to provide a more accurate risk prognostication for patients who have perioperative stroke, rather than just relying on the risk stratification that happens based on non-perioperative stroke risk factors, and perhaps identify some unique characteristics. So now I'm going to hand over to Jaycee, who's going to go through our analysis, our preliminary analysis from our study.
Okay, great. As Alana has just nicely outlined for us, it's evident that outcomes after perioperative stroke are not good, and gaps in knowledge still remain in terms of how we might be able to better manage and treat perioperative strokes. As Alana mentioned, current treatment and management strategies are largely deduced from non-surgical stroke populations, or previous studies have been too small in size to deduce significant conclusions from. So there's a need for a larger, more robust characterization of outcomes after perioperative stroke in order to better predict their likelihoods and make more informed treatment decisions. So if we move to our next slide, that brings us to our study that we're going to talk about with you guys today. And it's titled Outcome Prediction After Perioperative Stroke. So if we move to the next slide, we are going to discuss our overall aim of our study. So the primary objective, or aim of the study, not objective, is to create a robust multivariate model using the American College of Surgeons National Surgical Quality Improvement Program, or ACS-NSQIP database, to predict personalized risk of poor outcomes after perioperative stroke. And this aim is divided into two key objectives, with our primary objective being to derive and externally validate risk prediction models for 30-day mortality, which is our primary outcome, and secondary outcomes as well, being adverse discharge and length of stay after perioperative stroke, and identify key risk factors here for those. And our second objective is to describe temporal trends in mortality and secondary outcomes after perioperative stroke over our study period. And with these, we hypothesize that our model will be able to accurately predict mortality and these other outcomes after stroke, and we will be able to identify novel predictors specific to the perioperative period, and the incidence of poor outcomes after stroke will increase over time. So our next slide. Here, we're just gonna kind of briefly describe our data set. So the data we'll be extracting our model terms from is known again as the American College of Surgeons National Surgical Quality Improvement Program database, or ACS-NSQIP database. And this is a data source that collects information on over 150 variables for patients 18 and over undergoing major surgical procedures. It uses a systematic sampling process that runs on an 8-day cycle to ensure randomization, and the data is collected by the site's designated surgical clinical reviewer. They've validated their data set by conducting regular audits and revealing an overall disagreement rate of only 2% for all program assessed variables. It's an extremely large data set, as we can see here with the most recent year, including 902,968 cases from 706 sites. And the total data available comes out to around 9.6 million surgical cases between 2005 and 2020. And the size of this data set, as you can imagine, provides a really unique opportunity to analyze a large number of reliably collected strokes that would otherwise be quite difficult to collect. So moving to our next slide. In order to be included in our study, patients had to have undergone surgery as reported by NSQIP between the years of 2005 and 2020, and they had to have had a stroke within 30 days of their surgery. And this was determined using NSQIP's variable for postoperative complications and filtering for those who had a post-op complication of stroke within 30 days. And will exclude patients having intracranial neurosurgery, interventional radiology, or carotid endarterectomy because of their unique mechanisms of stroke. And on our next slide, we'll just discuss our primary and secondary outcomes for our study. So we will create a prediction model for our primary outcome being 30-day mortality and also length of stay and adverse discharge as secondary outcomes. We'll also describe our data and observe ICU utilization and severe stroke outcomes for our patients. So, and here we can just see that our markers of severe stroke outcome include craniectomy and tracheostomy and adverse discharge, like Alana said, essentially being a facility that's not home and home. All right, so now to get into our methods for objective 1, so creating our prediction models. In order to do so for our primary and secondary outcomes, we plan on conducting a logistic regression analysis on a reduced model that will undergo variable reduction by a combination of principal component analysis and just consideration of clinical context. A wide range of patient anesthetic and surgical factors will be considered in order to compile candidate predictor terms. And this will be based on clinical experience along with previous evidence from literature on outcomes after non-surgical stroke. And we'll stratify all of our analyses by cardiac and non-cardiac surgical cohorts. For hospital length of stay, on the other hand, we will analyze this outcome with a Poisson regression because of the discrete count nature of the data. And for our second objective, we plan on examining the unadjusted relationships between our primary and secondary outcomes with respect to the year of operation to look at our temporal trends. So in order to do this, we will further incorporate the year of operation as a covariate into our analysis. And to account for missing data, multiple imputation strategy was used, and we considered a range of 1% to 3% missingness acceptable for all of our analyzed variables. And so now we will start to discuss some of our preliminary results. So here you can see that after filtering for only stroke patients, our data set came out to around 18,806 patients. We excluded a number of people based on our exclusion criteria that you can see here. And what we ended up finding was a total of 862 cardiac surgery patients and 17,944 cardiac patients. And here we can see their both adverse discharge to facility and mortality rates. And just to note that discharge destination was a variable only included after 2011. So that part of our analysis will only include 2011 onwards. All right, so here we have selected just a few variables from our analysis describing our non-cardiac surgery cohort. So just to kind of have an idea of what our data set looks like. And here, as you can see, about half of our non-cardiac surgery cohort were female, 23% were emergency surgeries, and about 4% were dependent functionally. We identified many other post-op complications, some of which include myocardial infarction, renal failure, and cardiac arrest. And as well here, we can see surgical specialty was defined in our data set as well. And we can see the most common surgical types in our non-cardiac cohort were our general surgery population and our vascular surgery population being around 30% each. And on our next slide, here we're investigating or looking at the similar statistics for our cardiac surgery population. So here we can see about 320 of our 862 were female. And again, we're reporting the post-op complications here for our cardiac surgery population. So we can observe this above. Anyways, moving on to our severe stroke outcome analysis. So one of our first outcomes that we're going to discuss and results are our severe stroke outcomes. And so what's important to note here is a surrogate measure of stroke severity is craniectomy and tracheostomy and intensive care. And this is how we essentially evaluated stroke severity, because this is not a variable that's explicitly included in the NSQIP database. So a tracheostomy is usually employed when a patient is on the ventilator for a long time, and it's used as a means of alternative means of breathing. A craniectomy is when clinicians have to remove a piece of the cranium to allow for brain swelling. And then ICU utilization, we understand fairly well. And in this database, ICU utilization was captured by unplanned re-intubation or prolonged ventilation lasting more than 48 hours. So keeping that in mind, when we move to our next slide, here we are looking at the incidence of our severe stroke outcomes. And this figure shows that the incidence of tracheostomy and craniectomy were fairly low in both cohorts, but that ICU utilization was high, being 17% for both. The incidences were relatively similar between cardiac and non-cardiac surgery, but we see more frequent craniectomy in the non-cardiac surgery cohort and more frequent tracheostomy in the cardiac surgery group. So here we are just observing our primary or kind of main outcomes for perioperative stroke patients in both non-cardiac and cardiac surgeries. And here we can see a slightly increased mortality rate in the non-cardiac surgery compared to cardiac. And conversely, we see slightly increased discharge to facility in our cardiac surgery cohort. And then again, a slight increase in the rate of patients discharged to home in cardiac surgery when compared to non-cardiac. Overall, just important to note, mortality, we saw a 23% rate in non-cardiac and 17.9% in cardiac as our, kind of just to note as our primary outcome. So moving now into our next slide, we're looking here at some histograms showing the timing of strokes after surgery. And the most common is about 3 to 4 days after surgery. And we can see here the medians of both being 3 and 4. And here we can also see that cardiac surgery time to stroke was slightly earlier or weighted a little bit more heavily on the earlier side. And we don't know the exact reasons, but could be possibly due to the frequency of intraoperative stroke or increased monitoring level of cardiac stroke patients. So moving into our next slide and our next section, we're now going to discuss some of our analysis findings from our predictive models. And first, we're going to discuss this with respect to cardiac surgery patients exclusively. So moving into our first slide, first we're looking at things or factors that increase the risk of mortality after cardiac surgery stroke. And here we found that increased age and increased operation time. So this here we can refer to as a measure of complexity. So the longer you're in surgery, the longer or the more complex the surgery is likely. So we found that so increased operation time and increased age increase the risk of mortality after cardiac stroke. We found less days until stroke after surgery was associated with an increased risk of mortality. And we also found that the occurrence of myocardial infarction, postoperative myocardial infarction, cardiac arrest, and severe stroke outcomes were associated with increased risks of mortality or no presence associated with decreased risk, as we can see here in the table. Moving into our next table, we are looking now at predictors of length of stay. So things that increase the length of stay after cardiac surgical stroke was an earlier operation year, which is an interesting finding. The earlier the year, that increased the length of stay, or as the years went on, decreases in the length of stay were seen. Male sex was associated with increased length of stay as well as days from operation to stroke again. And then here we also see renal failure, history of congestive heart failure, no aortic surgery, bleeding disorder, weight loss, post-operative cardiac arrest, and severe stroke outcomes, as well as, or all of these are all associated with an increased length of stay, and then independent functional status with a decrease, but partially dependent functional status associated with slight increase in length of stay. And next, we're looking at predictors of adverse discharge. And here we found increased age predicted adverse discharge after cardiac surgery stroke, as well as, again, the surgical complexity or increased operation time, sepsis, an increased BMI, emergency status, and severe stroke outcomes. And again, increased days to stroke was associated with a decreased risk of adverse discharge. So now to discuss the same, but with respect to non-cardiac surgery alone. So next we will get into the predictors of mortality for non-cardiac patients. So things that increase the risk of dying after a non-cardiac surgical stroke was increased age, also found increased BMI, and poor functional status was associated with mortality as well. We also found smoking, COPD history, kidney failure, and myocardial infarction to be associated with increased mortality risk, as well as a partially dependent functional status. And here again, days from operation to stroke, more days equated to a lesser risk of mortality, and anemia was also found to be associated with mortality here as well. And this is in terms of patient-related factors. So we found many associated risk factors in terms of non-cardiac patients. So we've divided these into patient factors and then surgical factors for the sake of presenting them. So moving next into our more of these patient factors. Again, so here we can see that it also includes congestive heart failure, bleeding disorder, preoperative sepsis, weight loss, ascites being an indicator of liver dysfunction, all being associated with increased risk of mortality. We see ASA 1 or 2 with decreased risk, as ASA 1 or 2 are generally our healthier patients. We also see cardiac arrest and operation time and diabetes all being associated with increased risks of mortality as well following non-cardiac surgical stroke. And now getting into our surgical factors for predictors of mortality. So there's actually only 2 here that we noted to be significantly associated with an increased risk of mortality, being emergency status. So not being an emergency surgery was associated with a lower risk of mortality. So emergency being higher risk. And also general surgical specialties. So those undergoing general surgery were found to have an increased risk of mortality, interestingly. And we can just see that here as compared to our other surgical specialties as well. All right, so getting into now predictors of length of stay in terms of patient factors for non-cardiac surgical patients. So associated with increases in length of stay were male sex. If you were ASA 1 or 2 was associated with a lower length of stay, again, healthier patients, and increased days from operation to stroke was associated with an increased length of stay here. And additionally, this also includes COPD, congestive heart failure, sepsis, myocardial infarction, severe stroke outcome, and anemia. So all of those, the presence of them being associated with increases in length of stay. So moving next to our patient factors, again, for length of stay, we also see increases in age being associated with a decrease in length of stay here, interestingly, and independent functional status, so healthier patients, again, lower length of stay, and then diabetes, kidney failure, bleeding disorder, history of weight loss, and cardiac arrest, ascites, and BMI, all associated with increases in length of stay for non-cardiac surgical stroke patients. All right, here we're looking at our surgical factors in terms of length of stay for non-cardiac patients, and we can see differences here across our surgical specialties again as well. So interestingly, we can see general surgery, gynecology, et cetera, had associated increases in length of stay. And here we also see as the operation year increased, the length of stay decreased, interestingly. And something else that was interesting to note here was the significant association between the use of general anesthesia as compared to regional or local, and this association with an increase in length of stay as well in this population. And predictors of adverse discharge in terms of patient factors. Again, so we're looking at many here being increased age, independent functional status is a positive indicator, so lower risk of adverse discharge. And then again, diabetes, COPD, kidney failure, sepsis, cardiac arrest, severe stroke outcome, all associated with increased risks of adverse discharge. Here we see as days from operation to stroke increase, the risk of adverse discharge decrease. So another interesting thing to note. anemia, congestive heart failure, weight loss, myocardial infarction, all being associated with increased risk of adverse discharge. And then again, our ASA group 1 or 2, the healthier patients having a lower risk. So lastly, we're looking now here at predictors of adverse discharge for non-cardiac surgical stroke patients and the surgical factors that contribute to this. So here we can see significant associations in our surgical specialties, some differences seen across these here as well. And again, our anesthetic type conferring a significant relationship between general anesthesia, this technique of anesthesia, and adverse discharge. So general anesthesia being associated with increased risk of adverse discharge here as well. So now just to briefly describe, we're going to talk about the trend analysis now of our outcomes after perioperative stroke and how our models looked when operation year was incorporated. So this figure here shows mortality over the study period between 2005 and 2020, and the trend estimates are adjusting for age. And again, our overall mortality was 23% in non-cardiac and 14% in cardiac surgery patients. We didn't identify a significant trend over time here in either group, but we can note that mortality is consistently lower after stroke in the cardiac surgery population compared to non-cardiac surgery. So trends in terms of adverse discharge, again, so this was evaluated after 2011 onwards, and here we found a significant relationship in the non-cardiac surgery cohort that became even more significantly associated after adjustment for our covariates, and no significant change here over time, though we see a slight decline in our adverse discharge for both groups, interestingly. So lastly, these figures show the median length of stay with interquartile range over the study period. In both cardiac and non-cardiac surgery, the length of stay declined over time on both our unadjusted and adjusted analyses, with some stabilization since 2015. And these lengths of stay are considerably longer than typical for both cardiac and non-cardiac surgeries, which we can deduce from previous literature. And this observation is likely due to, in part at least, due to overall trends in earlier discharge from hospital in general now. And now I'll pass it back over to Alana to discuss some of the interpretation of these results.
Hey, thanks, Jaycee. So yeah, now I'll try to provide a little bit of context before we open for questions. So in general, what we found is that we were able to characterize in much more detail that has been previously published the sequelae of perioperative stroke after both cardiac and non-cardiac surgery. And we identified one of the largest cohorts of perioperative strokes that's available given the size of this database. So that's a useful addition. We found that all three negative complications of a stroke, so dying, having a long length of hospital stay, or adverse discharge, were all fairly common after stroke, which we knew, but we are able to characterize in more detail. We found many of the risk factors on our prediction models, especially for mortality, are consistent with a non-surgical stroke population. So that's actually reassuring that we were picking up similar risk factors as we would see in a stroke population that occurs outside of surgery. And we were able to adjust for many of the important covariates that should be in this model. Specifically, surgical complexity is a difficult one to account for in non-cardiac surgery because there's so much heterogeneity, but the operation time is consistently a good controller for that in terms of duration of surgery. We also were able to look within specialties, and we were able to use a surrogate marker of stroke severity, which we don't have a distinct variable for this, but I think we were able to capture the most severe strokes. And when you compare to the non-surgical stroke population, you can see I've highlighted the predictors that came out in our model that are very consistent with previous literature. So I think that's reassuring in our model. What is interesting about our results is that we did identify several novel risk factors that would be unique to the perioperative period that have not been previously identified. So I think one of the most important ones that we identified that was consistent was the temporal relationship to surgery. So it seems fairly robust that if you have a stroke within an early period after surgery, the closer to surgery you have your stroke, the worse your outcome. And that would make sense in a pathophysiologic sense, because you're having the most hemodynamic and physiologic disruption around the time of surgery, including hypotension, anemia, bleeding, transfusion, a whole bunch of other factors we probably don't understand. So that is an interesting relationship that we've described. In addition, we've identified key components, surgical factors that would predict worse outcome that could be used to risk stratify patients when deciding on treatment strategy. And anesthetic technique was not consistently a predictor, but it did come out in non-cardiac surgery as a predictor of length of stay and adverse outcome. Again, hard to know whether that's the meaning of that relationship in detail, but it does open up some interesting hypotheses about why that might be. And we do plan to explore these interactions further in our model and further analysis in the coming months to look at whether these are effect modifiers on outcome, if they interact with other patient variables specifically. Interestingly, we did not identify improvement in mortality rates over quite a broad study period of 15 years, or actually we did see adverse discharge changes. That is, the mortality benefit is an interesting observation, because in non-surgical stroke, there has been consistent reduction in mortality after stroke over the last 15 to 20 years. And that's across the US, across the UK, and even in Canada. So clearly there is a difference here in what's happening to surgical stroke patients versus non-surgical stroke patients. And it supports our hypothesis that this group of patients is under-recognized and under-treated and is a kind of a neglected subgroup of stroke. And that is worthy of further investigation, which we will be doing in a separate study. It is important to take into context the limitations of our analysis. Clearly, there is residual confounding. We're limited to the variables that are included in the NISQIP database. And so we can't adjust for everything that it is likely relevant. Specifically, important ones that we're lacking are hospital level data. So NISQIP is very careful to anonymize all data. So there is no identification of any hospital or even type of hospital in this data set. And that is likely a predictor of outcome after stroke. Stroke severity, we had to use a surrogate outcome, so it may not be fully accurate. And we are missing some likely variables that would have been ideal to include in the model, such as a history of stroke, which NISQIP for some reason dropped in 2015, so we weren't able to include it, and atrial fibrillation is not included. We also have a limited follow-up period, so our analysis is really limited to the first 30 days after surgery. We are unable to make comments about long-term sequelae and mortality. And in this specific data set, it's all surgical patients, so we can't directly compare to the non-surgical stroke population. We can only make inferences from the literature in non-surgical stroke. And then to just highlight what our plans are going forward in terms of our other studies. So what we're hoping to do with this prediction model, once we've finalized it, is that we will take the model and go to the linked BC administrative data set, so PopData BC, and try to validate the model in this other data set that also has perhaps refined the model as well with additional variables. And in addition, because using PopData BC, we'll be able to compare surgical and non-surgical stroke as well. So that's another whole aspect that we need to examine, is whether outcomes are quite distinct between those two groups, or maybe they're similar. So that's an important question to answer. We're also going to specifically look at the subset of patients in PopData who had a thrombectomy and look at their outcome after and see if that is just different between perioperative and non-perioperative stroke. And then as another side, linked but not directly related project, we're looking at screening tools for perioperative stroke and cardiac surgeries to try to identify these patients earlier and to improve their outcome after, if they do have a stroke, they get identified earlier. So with that, we will finish, and thank you for listening to us for almost an hour on this sunny day. But we do welcome any questions or discussion about our results or ideas that others might have in the group.